The 2018 guidelines were very clear that instant restenosis is the 1A indication, and the other vessel de novo were mentioned that there are some different trials, and there's no clear data supporting in guidelines the recommendation for the de novo lesions. However, the randomized study, which were done like Piccoletto tools with the 3 years follow-up, we know that DCB could be superior. We see the MACE below 0.005 in the advantage of DCB in comparison to drug-eluting stents. So it was an important trial, which was just this study to go with the large study and more experience for sure, but it was clear that we can consider the small vessels. A little strange is the recommendation nowadays in the newest guidelines 2024, when we see that DES is recommended over drug-coated balloons for treatment in DES restenosis. And as we discussed with the faculty, it will be a lot of discussion today probably on this topic. It was based on some analysis that target lesion revascularization could be lower with DES, but it was no safety concerns. But I think that this will be, and it will be discussed today and tomorrow. However, if we go for the more interventional approach with Euro intervention and well-known experienced operators, we know that still we see that the drug-eluting balloon are important for also the bifurcation lesion, especially when we use the two-stent techniques.
The chance to ask this question, but ask, the same questions to everybody. So, that the new guidelines have made, a very unexpected statement about ISR. So, question for you is, do you think that this new indication, 1A, for, DES in DES, when the failed DES is there in front of you, would ever be, let's say, used by the community, or DCB for ISR will still be there?
But,
we'll respect the guidelines, let's say.
But
1A is 1A.
I think I'm surprised.
Yeah.
Because I think to be so strong with 1A, if the problem is that you have to be very meticulous to prepare the lesion well before DCB. And you may have to use a stent. Sometimes it's okay. If you have a total occlusion, for example, of a stent, it's not easy to get away without implanting another stent. But those patients come back all the time. After 2 years, they will come back again. I have patients, not many, but I have one patient that has 7 stents, one on top of each other.
But not one inside?
Yeah.
Inside,
one,
7 layers?
7 layers.
Oh,
7 layers. It's still, but I think finally closed. But it took 8 or 9 years to close.
Okay.
I used to come every year. So, but I think, to me, I always use cutting balloon to prepare ISR.
Which is evidence-based. There is just one single study showing
there
that
is a study with a scoring balloon.
You have to do
by the
you are
group
supposed to do this, and it works. But honestly, I'm surprised because they didn't distinguish according to the size of the vessel, for example, or how old is that stent. And at least in theory, the logic is, as you just said, you can even end up with multiple layers of stent because, the rate of target lesion failure after in-stent restenosis is in the range of 20 or 30%. So the very unlucky patient will come back.
But for example, we always say that you have to do IVUS when you have an in-stent restenosis, you do IVUS, you say that you see that the stent is grossly unexpanded. You dilate the stent well now, with a good result. Why do you have to implant another stent?
I totally agree with you. Actually, we are all honestly discussing this because at some point, with all the due respect I personally believe that this kind of guidelines is misleading.
Maybe if you have a stent well implanted, you do IVUS, you find a lot of hyperplasia, you do cutting balloon, you don't take away the hyperplasia, of course. The result is a little bit shabby, maybe you implant another stent. So,
What if, in this example, what if, for example, you have a, let's say, a very thick layer of hyperplasia? You're not taking this hyperplasia out, so
No.
you put a much smaller stent inside a failed stent, if you see what I mean. I'm curious, honestly, because this 1A indication left me like speechless. Some kind of, well, I mean, it's not going to happen, at least in my practice, to be honest.
but it's based on the RIPS study, the RIPS.
Well, it is this meta-analysis.
Maybe
the
Jacobi, European Heart Journal. But you know, it's not.
I mean, the last study included, well, the most recent study included in that meta-analysis is actually back in 2006, so more than 15, almost 20 years ago. And obviously they didn't distinguish in terms of sizes or drugs or preparation.
And we keep on telling people that drug-coated balloons are not all equal.
Oh, yes.
So if you do a meta-analysis and you put together any type of drug-coated balloon, that becomes a weak meta-analysis.
It is.
So,
that's also one of the reasons why I don't really understand how honestly they evaluated this indication 1A. In my practice, the class 1A indication will not change anything. However, let's try to be pragmatic. In stent restenosis, to me, it makes a lot of sense to use a balloon because in the case that it will have, an additional failure, an additional procedure, you can use a balloon 100 times for this patient. This is not true for stent because obviously the logic consequence of 1A indication for the guidelines is that you may have 7, 8, 6 layers of stents in the same patient, regardless the size of the artery. And obviously, if the artery is a 4-row, first of all, it's really unlikely that we see an in-stent restenosis in a 4-row, except the case we did yesterday, and I will show you. But, provided that you don't have mechanical problems, a 4-0 stent, it's really unlikely it will fail. But in the case that it will, using a stent is not a major concern, because remember, the thickness of a stent is in the range of 70, 80 microns, altogether, including the polymer and blah, blah, blah. If the artery is 4 millimeter, the range, the magnitude is 10 times, 100 times, so it's not going to create any impairment in the flow. Obviously, it's totally different if we are talking about a 2.5 vessel, where 2 stents are immediately creating a late lumen loss, immediately.